I am Dr Sridhar Kasturi from KIMS Sunshine Heart Institute, Hyderabad. So today we are going to show 3-4 series of cases. I have my colleagues with me, Dr Sridhar, cardiologist, and Dr Kavya, cardiologist. And let me introduce my team members, Vasu and Venu, both are here, head technicians. And this is a 62-year-old male, hypertensive, diabetic, present with a chest pain of 4 days duration and worsening of symptoms during the past 24 hours. ECG showed rhythm junctional, but rate is intermittently showing episodes of AV block. Rate was almost 38 to 40. So echo showed RWMA and mostly limited to the right coronary artery. Let me show the angiogram. So angiogram showed severe triple valve disease, right coronary total occlusion, LMC a mild lesion, but it's not angiographically significant. You see the LAD, there is a tight lesion at the LAD D1 bifurcation, and there is one more tandem lesion at the junction of mid and distal LAD. And LCX is non-dominant. There is a borderline area of the LCX, and OM is showing the tight lesion. Right coronary total occlusion. So this is a acute MI, 4 days onset, ongoing pain, bradycardia, severe TBD, and critical lesions involving all the lesions with the C2 with the total occlusion of the right coronary. So what we thought, because the right coronary most likely because of the acute occlusion. So then only thing is it's a disease from the beginning. So when we were engaging the right coronary, there is a sudden pressure fall, damping, pressure damp was there. So then what we did, we took the fine cross, then with the fine cross we tried to negotiate with the Cyan blue, but we were feeling lot of resistance. We were unable to negotiate with Cyan blue. Then we went ahead with the Fielder XT. With the repeated manipulations, we were able to cross because in the bend there was a tight lesion. Then finally we could place the Fielder XT distally. We were attempting to cross it with the Fielder XT, but we could not. Then what we did, multiple dilatations, everywhere we try to top to almost proximal to distal, multiple dilatations using the 2 mm 1.5 because it was very tight. We used Riori balloon 1 into 10 mm initially, was 1.25 into 10 mm, subsequently upgraded. Now multiple dilatation, distal right coronary, go to the distal coronary, we used 38 mm and mid also we used again one more stent, that is also 38 mm, but proximally still there was a lesion. So but every time we were unable to place the stents without the help of guideliner. So you see we used Ginchbaum technique. Gradually we pushed the balloon, inflation, deflation, then moving forward the guideliner. Then subsequently we removed the balloon and placed the stents. So 3 stents were implanted, and proximally also we implanted 3 into 18 mm extending up to the ostium. So again multiple dilatations were given, and we used balloon tipped because the resting rate was low, a chance of going to complete R block very high if there is a slow flow, no flow, or because there is no support from the LAD and LCX. This is a final angio. You can see nicely opened the right coronary. So what we thought, okay, we will give a 1 day gap and give a adequate perfusion of the kidneys. We irrigated with almost 60 ml saline for 48 hours. This is the 3rd day of the procedure. Then you can see the right coronary, no dissection, expanded very well. IVUS we did, IVUS also showed very well expanded stent area. This is today's procedure. You can see the today's procedure you can show from here, from the beginning. Now femoral axis, last time we did through the right radial axis and temporary femoral approach. Now we used the right femoral approach. We thought the bifurcation of the LM is there, LED is there. If needed, double DK crush LED to D1 and DK crush of the LCX. That is extending the stent from the LCX to LM, crush it and put the stent and first kissing, then followed by another stent to the LED and second kissing, followed by the final kissing. That was our strategy. What we thought when we analyzed, LED diagonal junction is diseased and distal to the junction there is a lesion. What we thought will slightly dilate the diagonal, if needed use the cutting and DEB, and we put a stent from LED just beyond the ostium to the beyond the distal lesion. So we dilated initially with a 2 mm balloon. Entire LED proximal and mid lesions were dilated, and this is a dilatation. Then we did the dilatation of the diagonal. So when we analyze diagonal flow is good, reasonably. This is 2 mm, 10 mm, low inflations. Our intention, put the stent, provisional stenting of the LED. If there is a diminished flow or pinching of the diagonal is there, do the kissing and put a one DEB finally into the diagonal. So, but diagonal appears to be fine, flow is good. Our strategy is to go with the provisional stenting of the LCX. And then our intention is to go ahead with see the LCX, interrogate with FFR study and do the simple dilatation if needed DEB to the OM lesion and do the FFR study with the LCX. And LCX if it is negative, then no need to do any LM DK crush. So this is the strategy today. Then what we did the provisional stenting of the LED. This is 2.75 into 30I. See, while inflating, accidentally it came out. You see, the slightly moved into the. Our initial strategy is not to go ahead with the LM stent. So then accidentally it came, slightly projecting beyond the LMC ostium, and then for us no other choice. Then we dilated LM to LED stent, then multiple dilatation, pulled and high pressure inflation. The most important and critical step is you should avoid the LSD, longest distance. Once LSD develops, the restenosis rate is very, very high, because some studs are projecting to the LM. Naturally, when you engage the catheter or when you push the gear with the resistance, it can hit the proximal edge of the stent and it can lead to stent deformation. LSD is associated with 6.5% patients with LM stenting, and Excel study has revealed very clearly this is not uncommon, almost seen in almost 65% of patients who are undergoing left main, but many times not recognized on angio unless you analyze carefully. Here we suspected, then every time when we were passing the balloons, we were taking the help of the guide liner. With the guide liner, inch pump technique, put the guide liner deep into the LED and multiple. Before that, first and most important, you should do the part. If you part, if you do 2.7, if you do part, because it expands, even some struts which are extend to the aorta, it will retrieve because it expands. So then lead to shortening. So the projected portion will become less, and at the same time, when you place the wire, most of the time, if you don't engage and put the wire, it will go to the struts. It can go obliminally because LM is a big. This is a 2.75. So chance of going wire between the vessel wall and stent struts are very high. So again, when you put the balloon, again it may go obliminally and it can lead to, when you inflate, further worsening of the LSD and stent deformation. So here no, only gentle movements, push slowly, see that you are not hitting the edge of the. So here what happened, if you are, we tried to use the balloon directly, but it was facing lot of resistance. Then what we thought, we took the balloon and new balloon, don't try with the old balloon, new balloon because thin profile, enter into the LMLAD area, inflate and just beyond the proximal edge of this LM stent, inflate and slowly thread the guide liner into the LM LAD. So distally the lesion was uncovered. But we took the 3 mm, optimized the this is the distal optimization technique, and then LAD LM was dilated with 4.5 mm into 8 and 10. Even after 4.5 8 mm optimization, you see there is some studs are projecting into the aorta, then that area was dilated with high pressure. So if you have a big area, the chance of restorance is very highly. That is the reason we put the 4.5 you see. Now you see there will be resistance. In that case, never push the catheter without balloon. Now see here again we are dilating. Then we took the 3 mm balloon, because there was difficulty in negotiating. You see over the balloon we are pushing the guide liner. Now guide liner deeply placed into the LAD stent, then remove the if you don't use guide liner, if you don't use the inch bomb technique, it will become a hell. See, pressure will be failure, complication rate is high, acute stent thrombus high, resistance rate is rate, on the table chance of sudden reduction of flow is very, very high. Now we are removing, place the guide liner. Our intention is to cover the distal stent. You see the distal to the stent, there is a lesion. 15 into 2.75 mm stent. This is a Zion's expedition. This is a dilatations, optimization. And then we check the flow. LAD is flowing well, LM is stent is very good, and L6 is flowing very well. And you see there is a short segment lesion and it's a non-dominant considering age. What we thought, because LAD is nicely opened, the diagonal is flowing very well, right corner is flowing well. Our intention to do the stress thallium after 2 months. If the stress thallium shows any lesion, any ischemia of the L6 that time, but I feel for him it's a luxury because the LAD is flowing well, diagonal is flowing, right corner, he shouldn't have any problem. Thank you one and all for paying the attention. Thank you. Yeah, very good afternoon. I am Dr Sridhar Kasturi from KIMS Sunshine Heart Institute. Today this is the second live case transmission, and let me introduce my colleagues, Dr. Pranay and Dr. Partha, and I am thankful to all my cath lab staff. Today we have a hectic schedule, almost 5 interventions are there, all are complex. This patient came to us with severe LV dysfunction, almost congestive cardiac failure with a markedly elevated NT-proBNP. Let me narrate the clinical history. This is a 67-year-old male, known hypertensive and diabetic, presented with a recent onset of breathlessness but worsened over a period of 1 week, and associated with pedal edema, classically present with congestive cardiac failure features, markedly elevated NT-proBNP and NSTEMI presentation. And echo showed significantly dilated LALV, LV dysfunction severe, EF 30% and moderate MR, moderate PH. You see the NT-proBNP value 20,000 and DRAPA is 155, significantly elevated biomarkers, and HB was low, and he came to us with positive tuberculous bacillia and sputum. He has been taking the anti-cox therapy, which was started very recently. So then what we thought, we'll admit, stabilize, and CT chest was done. CT chest did show any cavity or consolidation. We were doubtful about the positive status of the sputum. Then we asked the pulmonologist to see, and 3-4 days we told at the time of admission it requires 3 to 4 days of stabilization of congestive cardiac failure, and then bronchoscopy was done. Bronchial aspirate was negative. So then today we planned for intervention. Show the angiogram pictures, and there is a short left main. We see the very critical lesion of the left main and LAD origin and L6 origin, and right corner you see very critical, and with today's angio showed almost VTIMI grade 1 flow, and now we will go to the. With this note, let me ask our senior colleague Dr. Shailendra Singh and Vijay Kumar Reddy with us about what strategy they suggest. Now our plan is to do the right coronary first because it's a large dominant vessel to give a backup LV dysfunction. We also we have started on temporary pacemaker support, mainly while doing right corner if slow flow, no flow is there, left main critical, elbow dysfunction, any Brady hypo, at least to support that one. We also prepared the IABP. Our plan is do the right corner stenting first to give the backup and then do the imaging of the LAD, L6 and the left main. If the imaging shows any significant calcium, our plan is to do the orbital atherectomy. If the assume that if that is not very significant, then we will go with a Wolverine cutting balloon and followed by the DK cross stenting. So that is our initial plan. So with this note, let me ask our senior colleagues to discuss about the case. Meanwhile, you can put the stent right corner. So we were facing a difficulty to cross the stent even with 3 mm N balloon, despite angiographically stent without any resistance. That is the reason almost all cases should be optimized with the imaging. So now we were forced to use the guide liner, and with guide liner inch bomb technique cross the stent. Now we are placing, put the Pranay, you can put the stent. So now you see our guide liner is almost at the distal end of the stent. Now we are placing the 2.5 into 15 mm stent. I see, now pull out.
Good morning to all. Good morning to all. Here today we are discussing one triple vessel changing RC, LMC, LAD and RCL DK crash. So the patient has got the 60-year-old man and STEMI is having severe LV dysfunction, not willing for a cabbage. His creatinine is around 1.4 and NT-proBNP is also elevated, who declined for cabbage. Now the RCA is showing the calcified lesions in the mid-RCA. The landing point after engaging and there is a block modification was done with and stent was put, there is another lesion in the distal end. Now the learning points are in this stage how to deliver stents in a typical delivery of balloons.
Akadaddu, 1 minute, pull, I will tell you.
Guideliner is a very
Sometimes what happens, so it discharges the stent. Balloon at the proximal end of the stent inflate.
after putting
Pull,
the first stent to
pull,
put the second
and
stent
then inflate and push the guide liner.
used
Guide liner is not there, kada? So no, it's not going distally. Okay, then go ahead, then no problem, go.
the guideliner
Because distally is it going?
balloon
Okay, then no issue, don't
while
worry.
deflating we have
Then
to advance the guideliner
that's enough. Don't go too distal.
destination point, then we can easily
Entire RCA do once again and come out.
and the stent is overlapped with the preceding stent with for 20 seconds at nominal pressure, then inflated at high pressure at the joint points. Then afterwards, post dilatation was done with the non-compliant balloon to achieve the optimal results. That's the learning point. So here the RCA will
Edge
learn
also cover
how
it.
to cross the, how to deliver
Still,
stents
still,
in difficult
Sini,
situation by using guideliner.
I think good.
By using bad technique. It's called balloon assisted technique. This guideliner was famous in force in 2011. Before that, there are no guidelines. It's very difficult to deliver the balloon substance prior to that area. Now it is now because of this new technology.
Small dose of necrorandilium.
Ready, sir.
Next I was
Now we can see the
Necrorandil. I was through, brother. Keep the guide liner. If any difficulty, we'll push the I was through the guide liner.
results, optimal results. You can identify the edge dissection.
Good.
You can see the position.
Push the wire slightly inside.
Those things we can assess.
Give the IVS
All
catheter.
those things. So angiography looks very good, but anyway, we'll confirm the results with the doing imaging, which is very, very optimal in this case.
Run. Auto. Flush properly.
We are doing IVS auto run from distal to proximally, seeing the area,
Distally.
position and expansion distance, any edge dissection, and area.
I think it needs distally also 3 ఇంకా చేయాలి కొంచెం. డిజిటల్ ప్రాగ్మల్ ఆఫ్ చేసారు మీరు. యూ డింట్ డూ ది డిజిటల్ ఆఫ్. సీనా brother, get me 3.5 balloon. See, large vessel. Yeah, nicely expanded, but compared to the vessel, distally stent appears to be undersized. I think 2.5 we can go up to 3.5 easily. I think pragmal you see nicely expanded. Okay, pragmal we expanded up to 18. So now pragmal segment of the stent is beautifully expanded, but distal portion where we have put the 2.5 mm stent, the vessel size is much bigger. So I think it needs to be optimized distal portion with 3 mm high pressure also fine. If you want to take 3, go with 18. Give 3, sister, give 3. Guideline is there, na?
Yes, sir.
Yeah. See, pragmal. Still, this is the pragmal portion of stent. It's a good area, expanded well and landed in a healthy zone only distally. Purge. See, vessel much bigger. Pragmal 3.5 untadi. Still push, purge.
Contrast.
See, undersized stent. I think we'll take 3.5. Distally 6A and pragmal high pressure out.
Stop.
See, the vessel size you see almost 3.5 to 4 pragmally.
3.5 తీసుకుందాం.
3.5 is 3.5 distally, only 6 చేయండి. 15 okay. See the stent starts and the outer layer. See, advantage of IVUS, you can see the expansion, apposition and any landing zone dissection is there or not. If the expansion is good, the long term results are better. See, for every 1 square mm increase of MSA within the limits of the vessel wall, there is almost 11% reduction in the mace rate. Just only 6. పుల్ చేసి 12కి వెళ్ళండి పర్లేదు. ఒక 5 mm పుల్ చేసి గో టు 12. But distally we landed in a very healthy zone. We didn't see any plaque and pragmally also healthy zone. So after IVUS, it changed our decision to further optimize with a bigger size balloon. So right side appears to be very good with we'll take final view, then we'll go to the left main stenting. At the time of doing left stenting, we wanted to give IBP support.
16.
Yeah. Good, Sini. After that we'll come out. Sini, de do. See, nicely flowing. Now nicely expanded. It is a bigger vessel. Come out. Epicranial. APR, elevocranial, anything, whatever you want.
Elevocranial.
See, good, extremely good result, nicely expanded stent, landed. See, it's accommodating 3.5, 6 to 8 mm only. Come out. It is important to use the IVUS particularly in high risk patients when you do the multivessel disease and patients with elbow dysfunction or severe triple left main vessel disease. Why? Because optimization is very, very important. So these patients, if there is an increased mace rate, it is detrimental. We have to provide the best results because patient is having a severe elbow dysfunction present with congestive cardiac failure. If you provide the best expansion and good apposition, the chance of stent thrombosis and chances of restenosis is very less likely. Suppose if you are not using the IVUS, we don't know, expansion is not adequate, then if restenosis is there, already bad LV, patient present with congestive cardiac failure, chances of events are very, very high. I want jail catheter. Finally, ఏమన్నా ఉంటే మాట్లాడు ఇంకా. You can discuss. Adjuvant, show doctor.
Now, the advantage of doing IVS in this case after the angiographic rate is good, but the IVS shows there is a under expansion. So IVS shows it's a very big result, 3.5 result. So after post dilating with NC 3.5 balloon, the angiographic result is very good. So the under expansion and malabsorption, they are very they are bad for bad outcomes for in terms of stent thrombosis and restenosis. Now with this we can assess and the result is excellent. Now we are putting ISDP
Arun,
and address the
Shailendra sir, IVS run LCX, LAD. After that we'll decide whether to do the plaque modification or not. Now we are connecting IABP at the time of LMCA because severe LV dysfunction is there. MCS support is required. We also discussed about the impeller, but it's more expensive for him. That is the reason we opted for IABP. Though cardiac output increment is only 0.5 liters, but marginally suppose patients with significant LV dysfunction relatively stable. Now the IABP is also recommended, but ideally FDA recommended impeller for protected PCI. When you do the high risk patients, multi-vessel, single surviving vessel, bad LV dysfunction, plaque modification is required, such cases impeller is recommended. But ECMO is not recommended for protected PCI. ECMO is recommended for patients who are with cardiogenic shock, cardiac arrest, who is prone for recurrent VT-VF cardiac. Those patients can be put on ECMO. Ideally cardiogenic shock, but protected PCA, impeller or patients relatively stable, you can go ahead because your pressures are maintaining well. We decongest him, decongest therapy was given, now relatively stable, he is able to lie down. That is the reason we opted for IABP to give some more additional hemodynamic support. Akkada, brother, camera dim.
Good morning, I am Dr Sridhar from KIMS Sunshine Hospital, and here we are doing an RCA and a left main and a LAD stenting in a calcified left main and a LAD. So the guide is 7 French.
7 French.
7 French guide is being engaged, and then there is car after crossing with the wire, they will exchange with the rota wire, and then we'll do an orbital atherectomy. And the orbital atherectomy is different from regular rotablator because it requires only one size is there. You don't have different sizes. And then depending on the rotation speed, you can increase the size of the ablation. You can, and the ablation is also occurs in both directions, both forward as well as coming back, reverse direction ablation happens. So this is much safer. There is lesser slow flow. There are lesser complications of the rotablator catheter getting stuck.
Direct calcium
complications are rare with orbital atherectomy.
Yeah.
So
Shall we proceed?
Proceed.
Yeah.
One.
Yeah.
Go. 210 degrees consist. You go wire.
Give another wire, brother.
Sir, I'll hold this.
Hold it. I'll advance it. Holding?
Yeah.
Small test. Small test. So this is once more demonstration of super cross, how to place the catheter to the. So now this is also going inside, then I'll make it straight, then I'm pulling the super cross. Show the catheter, brother. Yeah, inflate.
Yes.
Remove gently. Remove. Pull. Coming freely.
Yes, sir.
Come. Right.
Okay.
I am removing this balloon. Give IVS catheter.
DL.
Manual. Flush properly. Here disease there. I don't know. Injection, why it's not showing? Ikkada not
Because
much
critical
plaque.
అన్నట్టు ఉంది.
Not much plaque. Calcium. You see left main. See no? Left main calcium is there. L6 లెక్కి పోయినా అట్లా
అది కొంచెం డైలైట్ చేద్దాం సార్.
మంది చేసినా కూడా అంటే మైక్రోకాథెటర్ వెళ్ళింది కదా.
ఓకే.
మైక్రోకాథెటర్ వెళ్ళకుంటే
ఓకే.
if it is not going then we will go with brother go to the L6 view PA caudal, let me see where it is placed. Sure. L6 PA caudal. Show me the distal. I think ideal to do the L6 is critical. Yes, we'll do the orbital of the LAD. We can dilate slightly. Sure. Come nearer. If it is not going, we'll dilate and pass it.
Bed, okay.
See? Yeah, from here and up. But I feel L6 is not calcified. You see? This is the L6 ostium. Very critical, but LAD side calcified. See now, this is the L6 ostium. You can, that is LAD origin. This is LM distal. LAD balloon enough. Cutting balloon. Take it is there. Both are there. See, LAD calcium is there. Intermittently, I think disappear.
చేసేసి
You move it, manually move it. అక్కడ చూడండి, that is the calcium area. You can see na eccentric calcium move. You are unable to see the vessel circumference. See, LAD ostium is. We'll do orbital atherectomy of the LAD ostium. That's enough.
2, 6, 4, 6.
Deflate. Deflate. 2-3 times do it.
స్లోగా చేయాలి కటింగ్ వాల్వ్.
Do. Okay, one. I'll pull it. Slightly it slipped down. What I will do, you can rotate and push it so
Okay.
that
Okay.
you pull it. Do it now.
6.
Very short focal ostium. That's fine. Take this, put it on LAD. And do LAD, Pranay. Now the IVS showed no significant calcium in the L6 ostium, but lesion is very tight but very critical, involving the focal segment. So that's the reason more of fibrotic. What we thought, let us use the vulnerable plaque modification of the L6 ostium. And though L6 ostium, LAD ostium is also showing the calcium, but length appears to be very short. Then our intention is to do the Wolverine plaque modification of the LAD ostium also. We'll repeat the LAD run. Suppose if something wrong, we'll try to go with orbital. ఇక్కడ చేయండి, డూ ఇట్,
Go,
డూ
go.
ఇట్,
Wait.
ఇంకొంచెం పుష్ చేయండి, రైట్, డూ ఇట్, గో, యూ కెన్ గో టు 12, 12, 14,
14, 16.
deflate and do it, pull back, LMC ఎలా లాగ్ చేయండి కాస్త, ఇంకొంచెం, రైట్, ఐ విల్ పుల్ ది క్యాథెటర్,
Go.
యా గో హెడ్,
18.
do it, that's fine,
Come down.
deflate, come out, take the IVS of the, we'll repeat the IVS,
We'll take one picture.
take one picture, engage properly, take a good scenic, catheter engage, because the sinus, yeah, small test, now you take, now it's flowing well, even LCX also dilated very well, I think LED also appears to be, take one epicranial, we'll see the LED landing zone, I think preferable to put that IABP marker, take scene, yeah, fine, I think both, you can replace, you can put into this one,
Center.
yeah, that's fine, okay, come, that length is enough, you can
I'm coming out of the
come out, we'll take only LED run, no need to do the IBS run of the L6. I want a 3.5 balloon, brother, for crushing, 3.5 NC, give 15 mm, 3.5. తర్వాత స్టెంట్ 3 into 15 ఇస్తారా 12 ఇస్తారా 12 here plaque free, absolutely fine vessel, no plaque, anybody showing that, yeah, showing kada, this is a distal LED, IVAS pull back, HD IVAS, Sunshine has a luxury of having a all advanced equipment like HD IVAS, 3D Injuk registration, and we have a EP advanced system, 3D mapping, everything. You can see a tri-layer structure, plaque free, the image is very very beautiful and clarity is extremely good.
mark. Bookmark.
ఇక్కడ చూడండి ఫ్లోర్ మార్క్ చేయండి, ఫ్లోర్ ఇక్కడ యూ జస్ట్ మార్క్ దేర్, ఇంజెక్షన్ adequate flushing, run floor, yeah, running కదా, here also not much plaque, that is the branch, see, you can see the branch, no? Fluoro intermittently, see the diagonal branch, there is some calcium, as you said, we will go up to the diagonal branch, see here plaque, we can see there is a lot of plaque burden, though angiographically looking not that significant, there is a significant plaque burden, see there is some calcium, here also you have to dilate, you see na, 360-degree calcium, fluoro on, see that is the area you have to do the plaque modification, very tight. Here it's good, vessel is fine, but beyond that there is a tight,
Nodule.
yeah. That is not nodule, that is artifact, wire induced bias. LM but opened, only that portion will dilate. Flush properly,
Out.
come out,
Stop.
Fluoro. Though there is a almost 270-degree, but length is short.
Dilate once again.
Dilate. కమ్ ప్రాక్మల్గా వచ్చి హయ్యర్ చేయండి ఎల్ఎంలోకి Go to LM. ఇక్కడ 18 చేయండి అయినా 2.75. Go to 18.
20.
Deflate. Even ఎలవ కాడలరా అప్ టు ది LM ఆస్టియం దాన్ని కూడా చేసేయండి. Slightly pull back the catheter. Fluoro. Disengage. A small test. Disengage the left hand. Do it. Now go higher. 18-20. Come out.
22. Down. Center కదా సార్ this?
Yeah. Keep 315 into the LCX, 3.5 into 15 crushing balloon. LED. See. Hardly 5 mm. Very short left main.
But roomy answer.
Roomy.
You tackle this down lesion,
We'll leave it. పిఏ కార్డులు చూడండి లేదంటే వన్ మోర్ వ్యూ పిఏ కార్డల్లా డిజిటల్ లీజన్ రికార్డెడ్ ప్రాపర్లీ స్మాల్ ఆర్ఓ కార్డల్ టేక్ ఇందులో ఇంజెక్షన్ వేయాలి డిజిటల్ టు బి డన్ ఆర్ నాట్ విల్ డిసైడ్ ఎక్కడ ఓవర్లాప్ లేదు సిని ఐ థింక్ విల్ లీవ్ ఇట్ నో నీడ్ టు ఎండ్ అది స్మాల్ బ్రాంచ్ చేంజ్ ఇట్ టు ఈవెన్ దట్ డిజిటల్ వైర్ ఓన్లీ బెటర్ దిస్ సైడ్ ఓన్లీ బెటర్ రైట్ స్ట్రెంత్ లేదు యా 3 into 15
First balloon sir.
ఇది ఎంత 3.5 కదా
3.5 15
LED లో వేసి పెట్టు.
yeah keep it in LED
Okay, give me that next one.
you have to park distally
Yes.
not going ఏంటి ఇప్పుడు
Balloon profile.
వెళ్ళిపోయినా లీవ్ ఇట్ దేర్ యా స్టాండ్ లేదు దిస్ ఈజ్ ఎ వెరీ ఇంపార్టెంట్ స్టెప్ ఆల్వేస్ కీప్ ద balloon distal to the crusher segment. What happens, suppose if you are crushing the stent, sometimes when you place the balloon may not cross if the studs are projecting into the left main.
Come to yellow card.
ఇది కొంచెం మా మానిటర్ నీకు జరుపుకోం కాదు టర్న్ దట్ సైడ్ ఆయన ఒక లిమిటెడ్ వ్యూలో చూస్తామన్నాడు తోడా ఇంజెక్షన్ లేదు గివ్ స్మాల్ ఇంజెక్షన్ ఇంజెక్ట్ స్లైట్లీ పుల్ దట్స్ ఎనఫ్ దట్స్ గుడ్ సినీ డాక్యుమెంట్ దెన్ గో హెడ్ ఇంప్లాంట్ ది స్టెంట్ deflate, slightly pull the balloon, give one more inflation, slightly pull and one more, one more, 10, 12, pull 3 mm inside,
Just pull the guide.
I am holding, yeah pull, got it, no, slightly pull the balloon, go higher, now go to higher, now beyond osteum only,
Beyond the
fluoro.
Kin the
If you want slightly, kindoddu, we wanted to expand the osteum. Slightly push, slightly push.
yes. Adi kinda వెళ్తుంది balloon.
Right, now it's okay. Go higher. Go 18.
18 sir.
Go to 18. Why? Because the osteum of the LC extent should be expanded fully. So when you crush, the easy to cross. If you don't expand it, if it under expanded, very difficult to cross. This is the most important step. Whenever you are doing, fully expand the osteum of the LCX. Come out.
I'm taking the wire also.
Taking the injection and remove it.
Okay.
Inject and remove it. Take document. After that we'll see. Anyhow, you can enter. That's fine. You can remove. Keep it inside. No issue. Yeah, remove total.
Unnecessary entangle.
Yeah. Pull the balloon. Pull the balloon. A small test. Small test. Higher inflation. Go. 18. Deflate. Slip line. Slightly deflate. Go. We'll keep the catheter there. Inflate now. It's okay. Inflate now. Slowly inflate.
Slowly go.
Okay.
Higher.
10, 12,
18,
14,
20, 18, 20. Deflate. That because that is not yielded with cutting. It's okay. We can do it now. Deflate. Slightly push it. Now do again.
Relax
Go.
again.
Do it again.
Now it's
Go.
Go.
20.
Okay.
Deflate. That's fine.
Use the wire again. We need to recross.
Brother, take that fielder. Give that fielder wire. Easy to cross. Fine.
Filter, please.
Meanwhile, we can put the distal strength. Length will be more. 38 will not be sufficient.
Okay, recross is
Across చేస్తే.
recross
కాదు
is we'll do
డిజిటల్
first.
స్టెంట్ వేసినాక దిస్ సైడ్ వీల్ పుట్ ది ప్రాగ్మల్ స్టెంట్ రిమూవ్ పోతా ఒక్కొక్క నిమిషం అవి వేస్తూ ఉండండి మన ప్రాబ్లం ముందు ఎల్ఈడి వేసుకోండి ముందు ఎల్ఈడి వేసుకొని దాని తర్వాత ఎందుకంటే అవి డిసెక్షన్స్ వస్తాయి నో బ్రాంచ్ అది స్మాల్ టెస్ట్ ఎపిగ్రానియల్
Balloon stick.
సిఎన్ బ్లూ
వేసేయండి ఇప్పుడు వెళ్ళిపోద్ది చిన్న టెస్ట్ ఇవ్వండి అది బ్రాంచ్ అది గో హెడ్ ఇయర్ లీవ్ ఇట్ బస్ ఇదే బెలూన్ అది
అయిపోయింది వెళ్ళిపోయింది సార్.
ఫిల్టర్ ఎఫ్సి ఇవ్వండి
Will you filter, please? We'll cross.
ఫిల్టర్ ఎఫ్సి కీప్ ది will straight away will try. If it is not going, will use the again super cross. Now already we have crossed the distal start, proximal start only. Okay, then you to take the balloon, 2 mm balloon here mani dagara. I think easily went. This is the advantage of opening the axial stent. ఇది తీసుకొని నెక్స్ట్ 3.5 వేసి ఫస్ట్ కిస్సింగ్ చేశాను సిస్టర్ కీప్ బోత్ బెలూన్ 3 and 3.5
నెక్స్ట్ 3 తీసుకున్నాం తర్వాత
In the short 18 వేసి
ఏది?
318 వేసి then we take.
అదే అంత గురించి వీళ్ళు గోపిత్ 318 డిజిటల్ చేసేయండి 18 or 23 ఆల్సో ఫైన్ ఇక్కడ విల్ టేక్ బిగ్గర్ వన్ డైలెట్ ఆస్టియం ఓపెన్ చేయండి ఫస్ట్ డైలెట్ హయ్యర్ 18 20 యా డిఫ్లేట్
Just pull little bit and then we go up.
do it now 18 20 maintain deflate now 3 తీసుకోండి
Is a distal
Ready, Amiru?
bifurcation, Medina class 111. So in it's a 2 bifurcation region, we are planning for that. The best strategy is upfront loose end strategy, that is decay crush. Decay crush was popularized by
brother
Shen,
keep 2.5 Riori also
of course with other types of strategies like pull out. So decay crush. The steps of decay crush are the following. First, after engaging the left main, we have to pass wires both into the
Next end.
LED
Also చూడండి step
and
next end.
LCX and redilate both LED and LCX with 1:1 balloons. That is the step
Inflate.
number 1. Afterwards, we have to
deflate
pass a stent into the side branch, that is LCX
Stent
in this case, with 2 mm protrusion into the left main, keeping a 1:1 balloon in the LED. Then the LED stent is inflated
give
to
send
nominal pressure, and afterwards check for any distal dissection or not.
see here what we did because we are facing a difficulty to place a stent into the LED. Why? One is some calcium spur might have projected, another thing is some struts of the crushed stent might have projected into the LM confluence. So that is the reason, due to a lack of alignment. Maybe the stent is hitting the projection struts or some calcium spur. So what we did, we took the balloon and with the balloon inch bomb technique, inflate the balloon, cross it, and over that we have threaded the guide liner. So we place the guide liner distally, we cross the crushed segment. Now we are placing the stent into the LAD. So now you can see, yeah, come to arabicranial or epicranial. Can you give a small injection? Yes. 1 minute. Let me hold this one. So whenever you do any injection through the guide liner, always hold the guide liner. Otherwise, with pressure it may go distally and it can hit the coronary artery and it may dissect. This is the most valid point. Inject. I think fine, huh?
అవును సార్ కొంచెం కిందకి వెళ్దాం
ఇంకెళ్దామా? బట్ ఐవాస్ మనకు బియాండ్ బ్రాంచ్ ఓన్లీ కదా?
Before branch.
You want to pull it, huh?
Yeah, pull it.
It's okay, this is okay, landing zone, this fine. Table, I'll keep small injection,
we can
small
go down
injection.
sir.
I think down a better,
Down better sir.
Small,
There is some plaque.
I think this is fine. You want slightly distal?
Yeah, we'll go down.
Do it, that's fine. Yeah, inflate, deflate. Sir, you can go on.
So, the step number 1 is the placing a LCX stent with 2 mm protrusion into the left main and placing a 1:1 balloon in the LAD. Inflate the left circumflex stent to the nominal pressure 2 times, and after checking if there is any distal dissection, remove both the balloon and wire from the LCX. Then you bring the left LAD balloon into the across the circumflex, crush the stent. That's most important thing. Afterwards we can recross the circumflex artery proximally. See, in case of decay crush, you should always cross the side branch stent proximally. Don't cross distally. We have to cross with some 1.5 balloon to open the studs. Then afterwards we can place 1:1 balloon in the circumflex and the 1:1 balloon in the doing a kissing balloon. That is the first kissing balloon. Afterwards we have to pass a stent to the main LAD. So here after passing there is some difficulty in passing the stent. So we have used guide liner to cross it, and distally 1 stent is deployed in the mid LAD. Then afterwards we have to plan for the proximal LM2 LAD stunting.
Pull the guide liner. Come to elevocranial. Go to elevocranial. ఇంకొంచెం elevocranial. Small test. No, అంత వద్దు brother. Between elevo and epicranial. This is the one. Okay. Good, Sini?
Yes sir.
I think fine. కాలితే 1 to m. స్టెంట్ అంటే కాదు, ప్రాక్టికల్గా అంత పెద్ద డిసీజ్ లేదు. ఇంకొంచెం రాండి వెనక. క్యాథెటర్ వీ హావ్ టు పుల్. నో ఇంజెక్ట్. గుడ్ సిని. I think fine. It's fine. Good Sini. Good Sini. Okay. Distally covered.
Distally covered.
Okay.
We are overlapping.
If that is the case, implant, no Shinkin. Catheter in stent lo లేదు కదా, stent catheter లేదు కదా.
Bite on.
Okay, do it. Implant. Go higher. 14. Go higher. Deflate.
Come now.
Now we are implanting
2-3 times do it.
LM to LED stent across the crushed.
Do once again.
Stent.
Go up again. Effect.
So
I'll
next
go down.
step is pot. After putting this first pot,
Fully deflate diagram full చేయండి. Gently remove. It should not. No, not needed. That is bigger balloon. Come out.
Go. Overlap.
Right. Overlap. Huh?
14.
If it is going distally, also do it. Then no need to do NC there.
overlapping zone now is they are covering up with the high pressure, and afterwards there is a flaring of the left main RCM. Now the next step is first part.
Yes, I do. Do it here. That's well. Done. In Delhi, it is do only 8 distally.
Come to RO crane.
ROR epicranial, anything. I think you have crossed the stent. Kada?
Beyond the center.
You have to cine, under cine. Cine. Press the cine. ఇంకా రావాలి మీరు. I'll hold the guide. Cine press చేయండి, మీకు ఈజీ ఉంటుంది క్లారిటీ.
Yeah.
Now you are there. Go ahead. Only 6-8.
Yes, sir.
8. Don't go more than that. Yeah, come out. Give part balloon, brother.
దీంతోనే ఫ్లేర్ చేయాలి సార్.
ఇంకొద్దు ఫ్లేర్ చేసి దాని తర్వాత పార్ట్ చేసి
4.5 to 6.
ఫుల్ 4.5 into 6 కమ్ 4.5 6
Axial flash balloon. Unfortunately, we are not having the axial flash balloon. Now we are bringing the balloon outside the main stem, inflating to very high pressure up to 18 atmosphere, so that the stem is.
It's okay, it will come, pull out. It will come easily. Then take the part balloon. Let us do the part first. Because it's a short left main, if you are putting a long balloon, it may encroach onto the LED ostium, it may shift the carina. So for that sake, we wanted to, because short left main, we are using a special balloon, that is a part balloon. The advent of the part balloon, it doesn't have any shoulders, and it's a abruptly ends, both ends, without any shoulders. So shoulder induced injuries are less. It is also available in, before doing part, if you dislodge, the chances of entering into the abdominal is more likely. Anyhow, also. Now it's going without any hassles, then it's in the true lumen only, through the stent starts. Then do the part, after that we will take the, give part balloon.
గైడ్ లైన్
అదే స్టిక్కీగా ఉంది.
Pass the balloon too distally and then pull back to see any obstruction, any difficulty in crossing anything.
So for doing pot, the principles are you should end up the pot before the carina. That's number one. The objective of doing pot in left main is to prevent for
Next patient,
optimal
ready,
expansion and the
Next patient ready uన్నారు.
abdominal passage of air. It will prevent. Next step is to recross the LCX. Here always proximal or mid crossing only, not the distal crossing. Then this thing, after crossing, opening the studs and putting another balloon 1:1 in LED and LCX, doing a second hissing. DK crush technique, to cross the side branch, you should not use the reverse wire technique. That is one important point.
Give the 2 mm. Give 2, then 3, 3.5.
point about is about left main is we thought it is circular, but in fact anatomically it is not circular. It is a oval structure.
Dilate. LCX go to 12, go to 14, 15, 16. LCX. Yeah, that's fine. Deflate. Come out. We'll do repart, then IVAS and come out.
So the all upfront two-stage strategy. Kissing is mandatory. Without kissing, the results will be suboptimal because more metal, more like chances of stent
Small
thrombosis.
injection because of high pressure inflations. Let us see per here. Roll and repart and IVAS catheter ready పెట్టుకోమా వైప్ చేసి పెట్టాడు.
Now the balloons are removed. Now second and final part is planned.
Engage.
It should be followed by IVS to
Good. First class.
see the results of the study.
బాగుంది. Okay. We'll do repart, then final.
Firing time ఎప్పుడు
బాగా నెగిటివ్ చేయండి. ప్రొఫైల్ విల్ బి స్లైట్లీ బిగ్గర్. బ్రదర్ వాళ్ళది 5 mm బెలూన్ పెట్టిరా కాదు వీలర్ కాదు. ఐ టోల్డ్ దెమ్ టు కీప్ స్టాక్. ఇది అబాట్ దేర్ స్టాక్. దే హ్యావ్ 5 and 6 balloons now. అబాట్ రీసెంట్లీ లాంచ్డ్.
క్వాలిటీ చాలా బాగా వచ్చింది.
మంచిగా వచ్చింది. ఇట్స్ బ్యూటిఫుల్. ఈవెన్ ఎల్సెక్స్ బి పుట్ ప్రాక్మల్లీ కదా. Distally, our intention is to not to go ahead. And RCA shoes, LED open, luxury. Pull back. Small test. I think you are right. Go ahead. Dilate. Dilate. Good. కొంచెం ప్రాక్మల్ రండి. డిఫ్లేట్. ఎడ్జ్ కవర్ అయింది చూడండి. ఇఫ్ ఎడ్జ్ కవర్స్ లీవ్ ఇట్.
balloon 4.5 into 6.
No, I think over. వద్దు. You are beyond. Come out. స్మాల్ ఇంజెక్షన్ ఇవ్వండి చాలు. ప్రాక్మల్ ఎడ్జ్ చూసుకోండి. టెస్ట్. దట్స్ ఫైన్. గివ్ ఐవస్. ఫైన్ బ్రిస్క్ ఫ్లో ఐవస్ చేసేయండి సార్. అది ఫ్లో is directed towards sinus and this side. See, more of reflex because that is looking like that. When the LED is put the LED first. Brother, will you take manual? Okay, sir. Manual at take auto only. Take auto only. Because result is good, let us go slowly only. Patient is also stable. Going to epicrine. Fluoro. Show the fluoro. Go. Chalo, it's okay. Beyond, huh? Leave it, no issue. Run. You just purge, one of you purge. Auto. We are in the edge. Expanded well, opposed very well. Even circular opening. See, proximally also nicely expanded stent. Achieved a very good MSA. almost we got 3.5 mm diameter. Just press the fluoro once. Where are we? Now it is the overlapping segment, I think. Here. So despite calcium, it's expanded nicely. Normally, they may have asymmetrical expansion, and elliptical index also you can see. Is it more than 0.7 or less than 0.7? Area also very good area. One, two, three. 1, 2, 3, 3.25 like that.
1.5.
Now we are fluoro ones. I think coming to this is the LED ostium. Now the distal LM expanded well. Will slightly disengage so that the ostium also. That is iota. Come out. That's enough.
Stop. L6 తీసుకోవాలా వద్దా?
L6 చేయండి. We'll take L6 also. It will go. Wire is there. Everything is there. Let us document everything. We'll take from distal edge onwards. There is a plaque, but landing zone is very good. It's a plaque free landing zone. Stent is nicely expanded. This is also very well opposed. This is almost 3, almost 2.75 distally. Good, that is LED ostium. Freeze. Okay, live. Ainaka will take area.
Okay.
We reached to the ostium, then come out.
Stop. I'll take out.
Take out.
అవసరం లేదు కదా
తీసేయండి అవసరం.
వైర్ అనేది తీసేయండి.
Both remove and final injection. That's enough. Small test. It is there. Good, Sini. Good, nicely. Okay, come to avocado. That is branch. Because the branch overlap. Good, Sini.
Yes, sir.
Good, first class. ఒకటి take one arivocranial or epicranial, come out. Good, Sini. Entire LED. Oh, so many branches. Plethora. Nice perfusion. You'll have wonderful. Come out. Yeah. Now we'll remove IABP here only. He's maintaining well, Gada.
Yes, sir.
Now to summarize the case, this is a very nice complex case. Here, because patient presented with ischemic cardiomyopathy, elbow dysfunction, NSTEMI, markedly elevated NT-proBNP, TROP-I, and then right critical lesion. There is a LMC, a bifurcation lesion, very critical lesions. So what we thought, we will use orbital atherectomy, but IVS showed very clearly the L6 ostium, more of fibrotic, LED, though calcium is there, short segment lesions. In one area it's a 270 degree, but yielded well with Wolverine balloon. Then subsequently we went ahead with the cutting balloon, we have entered with the crushing of the L6 stent, that is 2.75 into 15 mm, crushed with the 3.5 mm balloon, recrossed, first kissing was done, and then distal stenting was done, LED stenting was done. Then again, after first kissing, we use the guide liner to cross the crushed segment. We place the two stents, one stent distally and one stent proximally, and 3.5 into proximally, distal we placed 28 mm, proximal we placed 33 mm. Then after implanting the stent, we did the pot using the 5 mm, 4.5 mm pot balloon. 5 mm length and 4.5. Subsequently, we did the second kissing after crossing the stent studs. Then again we did the repart, then followed by IVAS assessment of the LAD and L6. Both stents are nicely expanded without any malopposition, without any edge dissections. And we are concluding the case. In the IABP we are removing because of the LV dysfunction. We wanted to give a MCS support, and we are also removing the temporary pacemaker. Considering the severe triple L disease, critical left main and right coronary. So right coronary was done, L6 all were done in the same sitting. So this is the thank you now one and all for paying attention and watching this live transmission. Good afternoon to everyone. I am Dr. Sridhar Kasturi. This is the now. Yesterday he came to us with ongoing chest pain and with episodes of SOB, known diabetic and hypertensive. Underwent angioplasty in 2019, and ECG showed QRBB, echo showed RWMA in LAD territory with moderate LV dysfunction. NT-proBNP elevated, and the troponin is not elevated, but NT-proBNP 1190 and blood sugar 246, serum creatinine 1.67. So almost it's a near total occlusion of the LAD, distal to the stent because of the progression of the atherosclerosis. Initially, we thought of placing the wire, we were facing difficulty, then we put the fine cross. With fine cross, with little manipulations, we were able to place the wire in the distal LAD after crossing the tight lesion. Now these are the angiogram pictures. Let me angiogram, if you see, right coronary non-dominant. So here most important thing, left-sided system, L6 dominant. There is a very tight lesion of the proximal L6, and distal X also diseased. LAD, there is a mild block in the proximal to the LAD stent, but distal LAD very tight, very critical lesion. So now our intention is to the OCT guided LAD stenting and L6 stenting. Initially what we are doing, we are dilating with 1 mm balloon, then subsequently we will acquire the maximum go to 18 because only 1 mm balloon. Slightly go distally also, there is some more lesion distally. Yeah. Advantage of OCT, particularly in ISR lesions, mainly to assess the plaque morphology. What kind of plaque? The ISR may be within the stent or proximal or distal to the stent. It may be because of the progression of the atherosclerosis. This is edge restenosis. Proximally, a mild plaque is there, but distally also there is an edge which is very significant. So that's the reason we wanted to assess not that much. Yeah, from there you take. That's a good target. Good and forcible injection. If it's still inadequate, we will give some more dilatation. NTG given, huh?
Give me NTG.
NTG. This one complete pure contrast. Never mix with the blood.
Yes.
More blood, more artifacts. Image will not be good. Always give NTG prior to acquiring the OCT image, mainly to rule out any catheter related vasospasm.
What you have to do is you have to start first.
Simultaneously, we wanted to assess the stent status also. Any neointimal proliferation or neoatherosclerosis.
Fill.
Give force.
Fill.
Continue. Yeah, that's fine. Show the one of you can project the OCT angle. Still, you see, there is a thick fibrotic plaque. Then come proximally. Then you see here is very tight. This is a classic fibrotic lesion. Any fibrotic lesion definitely requires more optimization with the cutting balloon. So you can see very critical lesion. There is an area of calcium. Just go forward. You see, no? There is a calcium.
Thick calcium.
There is a thickness is more. If you see the thickness, almost more than 1 mm. Good. Just come to the stent. Here, that is a bifurcation site. Then come proximally and diagonal. Here you can see exact the distal end of the stent. The area is very good, 6.46 mm. Come proximally. It's absolutely very nice stent. And here area is 4. There is some under expansion in this area. Slightly go back. No, go back. 4. This is the 4. Distally 6, this is the 4 square. You can also see that the red mark is showing the under expansion. Come proximally. See here normal expansion. You expanded very well. Here also come proximally. Area is about 7. Come proximally. See nicely expanded stent. Here area 4.79. Here also there is come proximally. That is that bifurcation side. The stent LMCA normal, that is about 8.4. Come go distally. LMCA is not involved. Just slightly above. Rotate it. You can see the L6 origin there at around 50. Move forward. This is a LED ostium. Just to move inside toward the LED gently. Area, what is the area? 5.49. So that is not significant. They have extended stent up to the LED ostium. The ostium is 4.9. That means that area is good. No need to intervene there. There is no area of even a neoarthrosclerosis also. Move it. Move towards distal side. Move. See everywhere expanded well, but one focal area of move. This is the area we are concerned. This is about 4.61 and it is showing the red marker also, that is under expand. Go distally, but we will go to the exact landing. Slightly move out slightly. Still. You see, this is the distal landing zone. There is a thick fibrosis, but here luminal area is good. That means they landed in a very nice landing zone only, but distally there is a severe progression of the atherosclerosis, more of fibrous plaque. So this we will dilate with a cutting balloon before delivering the stent. Otherwise, it will not yield properly. We are taking, go distally. Yeah, that's fine. We will take the 2.5 cutting balloon. 2.75 cutting balloon there.
5 or 7 for this.
Run. Okay, view run. Previous. Show me the previous view. Arey Baba. Previous. Go back. Okay, go to the distal most segment. There. Inkocham move randi. Let us see the area. Slightly move this side. Inkocham. Still. Ikkada diameter telustadi. You are able to see periphery kada.
1, 2, 2.5. 2.5.
Otherwise 2.5 cutting, high pressure will go. Give 2.5 Wolverine. 15, preferably 15. One will dilate with 3.5 NC, one that focal lesion. Short of even lesion. 3.5, 8 unte 81. Co-registration anunda? That co-registration, okay, after this I will show the co-registration where that area of narrowing is there.
Acceptable.
Go. You dilate this after that slide. Is it going?
ఇక్కడనే ఉంది.
Not going, dilate here will, okay. Otherwise take 2 mm balloon. Subsequently we will take this one. Come out.
తర్వాత
We'll take 2 mm balloon iyyamma. Riori. Oh, ivu. 2 riori. అది చాలా టఫ్ ఉంది. అది ఎంటైర్ వెజల్ is closed. See, thick fibrosis. So the OCT also shows the etiology of the ISR in terms of is it neointimal proliferation or is it neoatherosclerosis. If neoatherosclerosis, is it because of lipid intima or calcific intima? And what are the other causes? Is it due to underexpanded stent? Is it due to any gaps between the stents, or is it because of the stent fracture, or any malposition is there? That it will show very clearly. Or any overlapped segments are reached. So overlapped segments, underexpanded stent, malapose stents, everything can be shown on
60.
కొంచెం కిందకి వెళ్తుందా ఫ్రీగా
వెళ్ళింది సార్.
ఒక ఇంజెక్షన్ ఇచ్చి ఎంటైర్ సెగ్మెంట్ డైలేట్ చేయండి. keep it inside the stent
Stent
and
and
give
then
injection. Good Sini. What will do?
కింద D విజయ
Just after septal until that one more septal is there. Kada? Until then until see you can see na freeze.
This faint septal coming.
Up to that you dilate again. Go distal slightly and dilate until that site. See,
Yeah.
slightly you have to move. 3 mm.
Go.
No, కాదు distally కావాలి ఇంకా distally. Small test. That is the site.
Go.
You can dilate. Take that cutting balloon. So after 1 mm balloon dilatation, we were unable to place the Wolverine because of the thick fibrotic tissue. Then what we did, we are taking the 2 mm balloon and dilating the tight portion, and then we wanted to use the cutting balloon mainly to further optimize the block.
Cutting.
Don't go that beyond that septal.
Yes.
Small test, Bhatia, just 1 cc. Don't give more.
Looks good.
Unable to see. Just
Baro.
push some more dye. Just the bubbles make it. Right.
So,
I think just 2-3 mm. 2-3 mm. Yeah, do it.
go.
Do it. Do it.
6, 8. Not more than that.
4, 6, 8.
Hold.
Wait for some time. We'll give 2-3 dilatations because it's a very thick fibrotic plaque. Deflate. Deflate and do once again. There only. Do it again.
Okay, sir. Going 10. 4, 6, 8.
Yeah, bus. Pull back.
Go.
Do it. Do it. One more dilatation is sufficient.
8.
10.
10.
You can go to 10. Vessel is bigger only there.
Go to 12. Till then.
Waist చూడండి. Deflate. I think it's gone.
Once
more
again.
you do it.
We'll go little distal.
We'll go a little distance.
Center. Shoot the wire.
We'll choose the landing zone with minimal plaque burden. Slightly move away. Bas. ఇంకొంచెం వెళ్ళండి.
Okay.
I think that's fine. You can. Ready, brother? Yes, sir. Take some more if you want to. Is it okay for you? On co-registration. Ready? You are ready?
I am ready.
Go ahead. That's fine. That's fine. Come out. We'll implant this time. See, it's a big vessel, but severe fibrosis. Come back. Go to distal. Go to distal. See, entire vessel is fibrous. Their area 2.38. Come this side. Come. Come. What we can do, pragmally will put stent and apply DEB. Go from there you move distally.
नीचे जाना.
Distally. Slowly. Still. This area. 1 minute. Just slightly come back. What is the area there? 3.78. Go distally. Still. Okay. What we'll do up to this is what is the length here? 32. Just see the diameter there, ELD.
Yes, sir.
May require distally some DEB or something. 2.78. What we'll do, give a run, a small injection. 32, we'll take 33. Good. What we'll do, up to that landing zone, we'll put stent distally, we'll use a small cutting balloon, then we'll do DEB.
Yeah.
Yeah. Brother, what you do,
Till that septal we can do. 33.
take 33 you give.
Okay, sir.
7533 will take, sir.
2.75. As per the vessel, 2.75 is there. Give me one 2 mm cutting balloon. Now run that OCT, brother. I'll explain. See, the distally vessel is big only, but fully, see, there is plenty of plaque burden. You can see the thick fibrosis, entire vessel is fibrosed. This is after cutting balloon. There is a definite significant gain in the luminal area. Deflate. Now push. Going. Slight move. There is slight movement. If that is the case, take 2 and we have a 2 mm balloon. Remove it. Take it out. We will take a
2 mm balloon.
2 mm balloon. Pull the wire. Pull the wire. Pull the wire. Now remove the. No, it won't go. Come out. You take. Sister, me the 2 mm balloon undi kada? Riori. Give 2 mm balloon. After that, we will use this.
We'll do 6-8 akkada.
Brother, ఒక మ్యాజిక్ టచ్ 40 mm పెట్టు 2 mm or 2.25. 2.25 fine. ఇంకొంచెం వెళ్ళండి. Go slightly. Do it from there.
4-6.
Deflate. It's okay. No issue. Pull.
Go.
Nominal 10, sir.
10, 12.
6,
Do it.
9, 10.
Deflate.
Come down.
మళ్ళీ సార్ చేయడు అక్కడే.
Go up.
Do again.
10.
Down.
Just 5 mm pull back. High pressure చేయండి.
Wire ठीक है. नीचे तक वैसा है अच्छा.
Do it. Now do it.
एक मिनट.
నేను అంతొద్దు.
అది గైడ్ ట్రబ్లింగ్.
The balloon was there కదా. Do it slightly. Do it there. Do it there. That's enough.
18.
16, 18.
Maintain.
Come down.
Come. Come out. Take DEB, brother.
नेगेटिव करो. नेगेटिव रख के रखना उसको. बार-बार करने से कुछ नहीं होता.
అట్లనే ఉంచండి. ఇట్లా అంటే
If
empty
you release that, na, it will not empty. You have to keep the negative pressure.
గుడ్.
This is good.
ఇంకొంచెం వైర్ లాగండి. వైర్ లాగి DEB వేసేద్దాం రండి.
Yeah.
గివ్ 40 మ్యాజిక్ టచ్ 40 అది 2.5
ఇది 2.25, 2.5.
2.25 35 దేదో మరి 35 చాలు కదా లెంత్. ఒకసారి చూడండి. రన్ చేపెట్టి స్టెంట్ డిస్టెన్స్ చూడు బ్రదర్. 35 షుడ్ బి సఫిషియంట్. ఇచ్చేయండి 35.
Okay.
L6 will do only pragmal and come out.
Yes.
That's enough.
Simple.
అది 2 డిస్టల్. ఇంకో కావాలి ఎంటీ కావాలి.
Give us OCT.
ఒక చిన్న ఇంజెక్షన్ ఇవ్వండి. 1 cc NC చేద్దాం. 3 into 8 ఒక 3 ఇస్తారా 3.8 ఇస్తారా. ఆడ వెల్ సైజ్ చూడు బ్రదర్. అది మూవ్ చేయి అక్కడికి. జస్ట్ గో టు ది 40 ఇంకా స్టిల్ డిస్టల్ అక్కడ ఏరియా చూడండి. డయామీటర్ 3.27.
3.35.
దెన్ 3.5 దేదో. 3.58. That's enough. There keep the co-registration there. Move the co-registration.
అది సెప్టల్ దగ్గర ఉంది సార్.
మా ఇంట్లో మనకు తెలుస్తుంది బ్రదర్. 3.5 పెట్టు. ఒకసారి అది మూవ్ చేయి. అండర్ ఎక్స్పాన్షన్ దగ్గర రా. కో రిజిస్ట్రేషన్ పెట్టి అండర్ ఎక్స్పాన్ దగ్గర రా. కీప్ కో రిజిస్ట్రేషన్ ఆన్. Just 8 total.
करो
8 వరకు వెళ్తున్నా
8.
6 8
That's
No.
fine. Then come out. No need to do anything. We'll take one OCT run, come out.
give me OCT.
Give the OCT, brother. Distally, small.
Okay, we'll see in the OCT.
OCT is this. Other option, we can keep a small string there. Only 2.5 into
15.
15. Okay, 2.5, 15 there, brother. Brother.
2.5 దగ్గర పెట్టుకోండి.
Go, no problem. We'll do it and we'll. OCT is this. It's a non-flow limitation. We can normally we can leave it also. Actually, resections only 2.5 feels well. 15. Okay, 2.5, 15 there, brother. Brother.
2.5 దగ్గర పెట్టుకోండి.
This is severe fibrotic. Without dissection,
छोड़ दो बाद में करेंगे.
normally we can leave it also. Actually, resections heals well.
पास
Only slightly pull away. He is severe fibrotic. Without dissections, it
छोड़ दो
will
बाद
not
में
heal.
करेंगे. पास
Now pull and do it again. Go now and then, that much. Don't come to the dissection edge. Now it will go. Only slightly pull the wire. Pull the wire, too much. Now pull and do it
इसको
again.
छोड़ो यार.
Now and then, that much. Don't come to the dissection edge. Distally. Now it will go. Yeah, from here we'll do it. That's enough. Pull the wire, pull the wire. Brother, properly engaged, check once. Properly engaged, check once. Good. Pass. Well,
Yeah.
flowing well. Brother, be ready. On. Go ahead.
छोड़ दी.
From here. Good. Pass. Well, the vibrating, you see.
छोड़ दी.
From here, that stent nicely expanded. The vibrating, you see.
మంచి ఎక్స్పాన్షన్ ఉంది.
That stent nicely expanded. There. Give me ఒక షార్ట్ స్టెంట్ వేసేద్దాంలే 2.25 వేసేయండి. లేదు 2.5 షార్ట్ స్టెంట్ కమౌట్ ఒక షార్ట్ స్టెంట్ 15 2.25 వేసేయండి. 2.25 షార్ట్ స్టెంట్ కమౌట్ 2.25 15. Hmm. 2.5 only short will keep. That's enough. Remaining that's enough. 2.5 only short will keep. That's enough. Will give 2.5. That's enough. Give 2.5 is not parallel. Will give 2.5. 15. 18 is not parallel. Give 18 also. 15. 18 is not parallel. Give 18 also. తగ్గిపోతండి, డోంట్ వరీ. 70 దగ్గర రెడ్ దగ్గర ఏరియా చూసుకో. 77 పైన 7 రెడ్ మార్కర్ వచ్చింది చూడండి. ఇంకా స్టిల్ ఇంకా సేమ్ ఉంది. 5 వచ్చింది ఇప్పుడు. నా బెటర్ కదా, ఇంతకుముందు 4.2 ఉండే.
ఓకే కదా సార్. ఇది
చిన్న ఇంజెక్షన్ డైరెక్ట్ అది ఓవర్లాప్ అండ్ దర్శనం.
అందుకే చెప్తాను.
ఓవర్లాప్ ఉందా?
एक मिनट
ఇంకొంచెం రండి ఇన్సైడ్. డూ ఇట్ ఇన్ఫ్లేట్ 10-12 పెట్టండి. ఇంకా
6 8 9 10.
ఇది రెగ్యులర్ స్టెంట్.
डिफ्लेक्ट
एक बार फिर जाए.
Do one hand, pull back, high pressure.
Okay.
गो
10.
डाउन
Pull it slightly, go to 18, 20.
जो
20, 22.
20.
डिफ्लेक्ट
Come out, that's enough. Inject and we'll remove it. Good, first class one. Remove the wire. Put it to the L6. Brother, come to yellow cardle. రూమ్లో పెట్టి హ్యాంగ్ చేసి పంపించాను నేను. స్మాల్ టెస్ట్ ఇవ్వండి ఫస్ట్. అదే బెలూన్ పోతుంది చూద్దాం. ఇంజెక్ట్ దట్స్ గో హెడ్. ఇప్పుడు నాట్ గోయింగ్ విల్ గో విత్ సింపుల్ బెలూన్.
ఇది ఇవ్వాలి.
స్మాల్ టెస్ట్ ఇంకొంచెం వెళ్ళండి. దట్స్ టెస్ట్ డైలేట్ గో.
గోయింగ్ సార్.
ఇది ఎంత లెంత్ బ్రదర్? 10.
6కి వెళ్తానా?
8, 10, 12, 14 డిఫ్లేట్. ఈ స్మాల్ బెలూన్ 2.5 డిఫ్లేట్. అక్కడే ఉంచండి. గివ్ ఇంజెక్షన్, దెన్ విల్ సీ ద లెంత్ ఆఫ్ ది లీషన్. డిఫ్లేటెడ్, రెడీ ఫర్ ఇంజెక్షన్ బ్రదర్. సీని రికార్డ్ చేయండి.
1 minute.
So we will go up to slightly go and cut the lesion, then we'll take 15 కాదు ఇది, 18 should be sufficient. Take 18, 3.4. Do it, that's okay, do it, go. 18, go to 18, 18, 3 ఇద్దామా 3.5 ఇద్దామా? 3.5 పెద్ద ఉంది వెదల్. ఇట్స్ టూ బిగ్. నేను ఎంగేజ్ నవ్ ఇంజెక్ట్. కొంచెం వెళ్ళండి. స్మాల్ టెస్ట్
గైడింగ్ ఏజ్ ఉంది సార్.
నా అక్కడ స్టక్ అయింది, ఒక్క నిమిషం. ఐ విల్ స్లైడ్. టేక్ రెగ్యులర్ బెలూన్. ఐ విల్. ఇప్పుడు వెళ్ళిపోయింది స్మాల్ టెస్ట్, వెళ్ళిపోయింది స్మాల్ టెస్ట్. అక్కడే ఆగింది, వెళ్ళిపోయింది. ఇప్పుడు ఒక్క నిమిషం 1 minute. లెట్ మీ పుష్ ది వైర్. నవ్ స్మాల్ టెస్ట్. డూ ఇట్ హయ్యర్. 18, 23 అవుతామా? రైట్ డీప్లైన్. ఇక్కడ ఒక ఇంజెక్షన్ మనకు లెంత్ తెలుస్తుంది, మనం డిస్టర్బ్ ఎంత చేద్దాం అనేది. అంటే కింద ల్యాండింగ్ జోన్లోకి ఎంక్రోచ్ కావద్దు అంతే. సఫిషియెంట్ లెంత్ ఉందిలే. ఇది 15 కదా, 23 ఇచ్చేలే, అక్కడ దానికి వస్తుంది. కమ్ 3.5. ఒక్క నిమిషం ఇది పట్టుకోండి. ప్రాగ్మల్ కట్ చేసేదా? గివ్ మీ. నిద్ర వస్తుందా? దగ్గొచ్చు, పర్వాలేదు తగ్గిపోతుంది. కొంచెం లాసిక్స్ ఇవ్వండి ఆయనకు, ఒక 20 mg ఇవ్వండి. ఎల్బి డిస్ఫంక్షన్ ఉంది కదా. స్మాల్ టెస్ట్. ఇంకొంచెం వెనక రావచ్చు. స్మాల్ టెస్ట్. ఎల్లో కార్డులు రా బ్రదర్. రెడీయా మీరు? ఐ థింక్ పర్ఫెక్ట్ ఉన్నాం. పర్ఫెక్ట్ ఉన్నా. గో హెడ్. డిఫ్లేట్. చిన్న పఫ్ ఇచ్చి విల్ గో హై ప్రెషర్. ఇంజెక్ట్. గుడ్, గో హయ్యర్. 18 దానికి వెళ్ళొచ్చండి. 18, 20,
16,
20, డిఫరెంట్
అదే సార్ మధ్యలో వెళ్తాం సపరేట్గా వెళ్దాం సార్ వేరే ఎంసీ వెళ్ళి
అయినా బాగా అది షోల్డర్ ఎఫెక్ట్ కదా దానికి అంటే లెఫ్ట్ మైన్ పెద్దగా ఉంది కదా లెఫ్ట్ మైన్లో ఏమి ఇంజురీ కాదు ఎన్సీ తీసుకో 3.5 ఇచ్చేయండి ఇవ్వండి 3.58 ఇచ్చే
సార్ లెగద్దు
కొంచెం సార్బిట్రేటివ్ బ్రదర్ సబ్లింగ్వల్ ఇప్పుడే వేసినా కదా ప్లాక్స్ కిందికి వెళ్ళి ఉంటుంది ఒక సార్బిట్రేట్ సబ్లింగ్వల్ ఇవ్వండి బ్రదర్ టేక్ వన్ గుడ్ సిని రెడీయా మీరు లేకుంటే పిఏ కాడలు తీసుకో బ్రదర్ బ్రాంచెస్ అన్నీ పడతాయి టేబుల్ ఎంటైర్ బెజల్ రెడీ బాగుంది 3.5 తోటి చేద్దాం లేండి సార్ ఇవన్ ఎకరానిద్దాంలే ఇది నామినల్ చేయండి ఇది
ఓకే
అయిపోయిందిలే
7 ఇచ్చినాం సార్
7 ఇక అయిపోయింది కదా మనకు
అయిపోయింది సార్ కొంచెం బ్యాక్ రావాలి
డూ ఇట్
12
డిఫరెంట్ డూ ఇట్ ఓకే కొంచెం కిందకి వెళ్ళి డూ ఇట్ ఓన్లీ 10 12 డిఫరెంట్ do it
12 సార్
different brother come to yellow cardal table అంతే ఉందిగా
బయట ఉన్నాం సార్
బయట ఉన్నామా ఇప్పుడు నా ఫైన్ గో హెడ్ just 8-10
8-10 సార్
bus that's enough deflate give OCT last view అంతే 2000 ఇచ్చేయండి పర్ గివ్ 2000 కొంచెం సార్బిట్రేట్ ఇచ్చిరా నెకరాండలు ఇచ్చేయండి అవి ఇంటర్కర్నల్ ఇచ్చేయండి
ఫస్ట్
గో హెడ్
గోయింగ్
వెరీ గుడ్ బస్ సో we did the LCX stent ఇట్స్ ఓకే అయిపోయింది కదా వచ్చేసింది ఆఫ్టర్ దట్ గాన్ ఇట్స్ ఓకే వీ గట్ ద ఇమేజ్ కదా వీల్ టేక్ ఎ నైస్ సినీ అండ్ కమ్ అవుట్ సో we did that is 3 or 3.5 stent Venu 3 or 3.5 So we implanted 3.5 into 23 mm stent, measured the length on OCT, diameter was measured on OCT, and then subsequently we did post dilatation with 3.5 mm. So excellent result. Then we are showing the final angio views. Ready? Inject.
Yes, sir.
Very good. Go to epicranial. We'll show the LED final view. Then we'll come out. Okay, entire vessel will show. Okay, sir. Good. So you come out. So here the case where diffusely this is LED, the distal to the previous stent, we use the stent, then distal portion of the LED, because that is also diffusely diseased with fibrosis. We used cutting balloon and DEB applied, but distal to the second stent there was a mild dissection, so non-flow limiting, but anyhow because it's a big vessel, they implanted one more 18 mm into 2.25 mm stent. Subsequently L6 was stented. So case with previous stenting critical lesion of the LAD, LV dysfunction, LCX lesion, image guided stenting, and DEB with a block modification. Thank you one and all for paying attention. We have shown 3 complex cases, and we will again repeat the same live telecast next month. Every month we are going to conduct live transmissions morning to evening. At least 3 to 4 cases we will be doing. Mainly we will focus on complex PCA using imaging, bifurcations, ISR lesions, calcified lesions, left mains, CTOs. So in addition to this, then we will also include structural interventions. The main intention is to show more complex PCA for education purpose. I hope this session helped all of you. Thank you.